One way I think about strengthening is comparing it to drinking water or hydration. That is, strengthening or drinking more water is not usually the therapy that is most needed, but both are important to health. I absolutely want people to be strong. I myself weight train at least 5 days a week. I want to be able to do push-ups and pull-ups and sprint and squats, and I want my patients to be strong as well, although I don't think that everyone needs a gym to be strong. And I want people to be hydrated and drinking water. But I think we really overestimate how much therapy should be strength-based. That is, how many musculoskeletal or orthopedic disorders are in fact due to or caused by weakness. I find that most orthopedic disorders are due to a joint being tweaked, a joint not mechanically moving well, which, as one of its possible sequelae, can cause weakness. That is, if your shoulder is not moving well or your neck is not moving well, and I test resisted shoulder abduction, it may be weak, or resisted shoulder external rotation. Those are the top two muscles I find weak when there's a mechanical problem in the spine or the shoulder and the patient's presenting with spine or shoulder complaints. That's my point, is that so much of this weakness is not truly weakness at the level of the muscle. It's something mechanical that's causing the muscle to present as weak. We could use the word inhibited, maybe mechanically disadvantaged. There are different words, and the actual pathoanatomy and pathophysiology is not entirely clear. But when you do a movement and you see strength restore in minutes, you come to understand this phenomenon is real. And you start to realize, like I did when I started to use repeated movement testing, that all these I's, Y's, and T's, all these rotator cuff band exercises in the upper body, all these things in the lower body like clamshells and donkey kicks and side-lying hip abduction, they're not usually needed. And the fact that people get better doing them is a great question. Maybe they're getting better because they're just moving. Maybe they're getting better because of the other parts of the therapy. But I'm putting forward the idea that they're probably not getting better because strength has returned. If that is the case, we would need to do just the strength training, and we would need to see a corollary with strength and pain. However, we should not be measuring whether a therapy makes someone better by whether or not their pain goes away in and of itself. We need to be measuring if the therapy is useful and effective by the pain going away and the disorder restoring to normal. Full range of motion, full nerve extensibility, full strength. But going back to strengthening, there are so many patients who are doing all those things that I used to, in fact, prescribe. I know this because I did this. I prescribed all those hip abduction. I prescribed all that clams, crab walking, monster walks, all those things that I thought were returning strength to the abductors and the extensors of the hip, for example. And I did a lot of core strengthening. But now that I can find mechanical problems that restore strength quickly, or mechanical problems that fix the disorder quickly, I don't really prescribe much strengthening. And outside of mechanical disorders, which I find to be the largest bucket of orthopedic disorders by a long shot, we find tendinopathies. And I don't even use the word strengthening with the tendinopathy. Some people might say, yes, we are strengthening the tendon, but I think of it as kind of just remodeling the tendon. That's the word we use in a lot of the literature. There's something dysfunctional about the tendon's ability to handle load, and we're fixing that by challenging it with the productive, painful movement on a regular basis. But I really don't even think of that as strengthening. A lot of the times, you'll take a patellar tendinopathy or a lateral elbow tendinopathy, and the person will have strength. It's just painful. So it doesn't make sense to me to argue that we're strengthening that patient. There are, of course, a cohort of patients that do need to become stronger. They're generally weak from being too sedentary. They're weak from 2 months in a hospital setting. They're weak from any number of things, and that's usually global. But for these vast majority of people who are in outpatient physical therapy, especially more active people, we are dosing them and prescribing strength when they don't need that as the primary part of their therapy or as the focal point. We need people to be strong. We need people to be drinking water, but it's not part of therapy that I find when I assess people that the strengthening is what's going to fix them. I encourage people to get strong, but in the limited amount of time that I have with people, I want to teach them habits that will keep them moving well and staying strong, or the muscles getting the nerve inputs that they need in the future. And I don't think we need to be strength training on a regular basis to stay pain-free. I think we need to understand mechanics, and we can do strength as an adjunct for that, for musculoskeletal resilience, for glucose metabolism, etc. So rethink your therapy if it's focused on strengthening. Most times, if we test that the hip extensor is weak, or the shoulder external rotator is weak, or the triceps is weak, we can fix the problem in the spine with a simple movement or two that we may take a little bit of time to find, but we found it. Or the extremity joint, like the shoulder joint or the hip joint, if we get that mechanically moving well again, you will see strength return, and then we will know if strength returns, range of motion returns, nerve tension abolishes, and symptoms abolish, we will know that we've actually reversed the disorder.